Good afternoon, everyone. My name is Gergana Koleva. I'm a project manager at Vital Transformation, and welcome to this webinar on European differences in heart failure registries. Our discussants today are Dr. Rachel Studer. She's a Global Healthcare Systems Evidence Therapeutic Area Lead and Head of Real-World Evidence for Cardio, Renal, and Metabolism at Novartis. Dr. Alicia Aul. She's Assistant Professor in Cardiovascular Epidemiology at University Medical Center Utrecht. And Dr. Stefan Kutztal, who is Assistant Professor at the Division of Heart and Lungs at the University Medical Center Utrecht. Before we start, I'd just like to make a quick housekeeping note. If you have any questions during the webinar, please submit them through the Q&A button below, and we'll be taking audience questions in the latter part of the webinar. And now I will hand it over to Stefan, who will give a brief overview of the topic. Stefan, over to you.
Thank you so much, Gergana. And good evening, everybody. So it's my pleasure to sort of set the stage. We'll be discussing differences or similarities in the European heart failure registries. So a couple of notes. So heart failure is a very prevalent disease, particularly in the elderly. And as a cardiologist, we frequently obviously encounter heart failure, but it is not just restricted to cardiology. And a lot of physicians in primary care nursing homes also have patients with heart failure. And it's a considerable disease burden with a high morbidity and mortality. So if you look at the textbooks we've been studying as we were medical students, you know, the prognosis is very grim, outweighing a lot of cancers today. But actually, whose prognosis are we referring to? And if you look at all the textbooks and the prognosis we have so far, a lot of that came from actually the clinical trials, which, as you can see, is on the far right end of the spectrum. So if you look at the patient journey from being totally healthy to have self-reported symptoms and a first established diagnosis, clinical trials capture the end, where patients have frequent heart failure hospitalizations, and ultimately, as I said, a lot of patients die from heart failure. So observational data are very crucial to advance knowledge about heart failure. And I think this sort of shows, if you see the Dutch national soccer team as the theory, so randomized clinical trials, you know, they look like they capture a lot of patients. They do, you know, there are thousands of patients captured in trials, and we do meta-analysis with them. But if you look in practice, they only capture a fraction of patients, in this case with heart failure. So we would like to make the argument that disease registries are very important, and not only registries, but also electronic health record data. So big data as a buzzword, if you will, I think are so important to really increase our knowledge about clinical trajectories, pathways, how patients travel from being healthy to go on to develop heart failure and ultimately endure heart failure hospitalizations. So that's sort of to make the case for the registries. I'll be happy to turn it back over to you, Gergana, to discuss some of the insights we've been able to get with those registries.
Thank you very much, Stefan. To get started, I would like to direct my first question at Rachel. Rachel, most heart failure registries, as we know, are national or local and do not capture data across countries. And also there is often no data standardization allowing for easy data comparisons between these registries. Your recent study, Report HF, which was sponsored by Novartis, took a different approach. What was that approach and what were the results?
Yeah, thanks very much, Gargana, for the question, and good evening, good afternoon, everyone. It's a great pleasure to be here. So I'm very happy to share, also based on publicly available information, how we approached Report HF and what we have learned from it. Now, we've just heard from Stefan around the representativeness of the patient. And actually, when we assessed the registries available at the time when we planned Report HF, some of which are super robust registries, but with some limitations, this was one of the key aspects we wanted to keep in mind. How can we ensure representative of the patients as much or as close as possible to the clinical practice? And as a result of this, there are some specific features that we planned into Report HF and into its design that should facilitate this. The first one was around geographical representativeness. Now, Report HF is the first truly global registry for heart failure. And in fact, it covered all 7 regions of the WHO geographies of the world. It was sites, and we have data for 18,800 and a few more patients. So this really allowed to get a global perspective on the heart failure patients and the burden of heart failure. And because the data was collected in the same study, in the same way, in a consistent manner, allowed for comparisons of the patients. We also included both patients with new acute heart failure, so newly diagnosed patients, as well as patients with chronic heart failure, but suffering from decompensation. So this was to capture the acute phase of the disease, as well as patients who already are in a chronic state. And with that, of course, also the place of care and the follow-up becomes very important. So we have many registries that focus on acute in-hospital care, while in Report HF, we followed patients for 3 years, so also followed them up into chronic care, usually or often also then conducted in primary care or in different settings of the healthcare system. We also looked at kind of consecutive recruitment of the patient. And that's quite important because, as with any study in observational studies, we often have some bias in selection of patients into the study. So by inviting the investigators to recruit or ask patients to join that they see consecutively, that is somewhat reduced, which was an important aspect also in the study. Now, without going on for too much longer, of course, there was a lot of emphasis put onto the level of depth in terms of variables that we collected. So to really have a detailed understanding of the patient characteristics, the etiology of the disease, and then the longer term outcomes as well. And overall, that really resulted in a unique data set in terms of breadth as well as depth that allows to understand patients on a national level, but also draw conclusions and comparisons between countries or regions as well.
Thank you so much, Rachel. That really gives us an overview of the scope of that project. Obviously, it was a very ambitious undertaking. Can you give us just a brief overview of the differences in outcomes for heart failure across Europe, and why are the differences as pronounced as they are, or as they seem to be, between East and West, Eastern and Western Europe?
Yeah, no, of course, be happy to do that. So interestingly enough, there are a lot of similarities in terms of the patient characteristics across the world, but there were also striking differences in terms of the patients themselves and then the management and outcomes of the patients. And one of the very impressive ones, and of course very important from the patient perspective, is differences in terms of survival. And to focus on Europe, we did see quite clear differences in terms of outcomes between Eastern Europe and Western Europe as well. So to give some specific numbers, the reported inpatient mortality in Report HF was about 2.4% across the world, but 1.5% in Eastern Europe, being actually the lowest across all of the regions assessed. Now, sadly, also many patients still are rehospitalized or die after they have been discharged from hospital. And the mortality, 1-year mortality after discharge from hospital across the world was about 20% in report HF, but again, lowest in Eastern Europe with 16%. And Western Europe was 19%, so very similar to the world average. The world as much as represented in report HF. Now, part of mortality, there's many predictors, which include the severity of the disease, the age of the patient, and many more. But one thing that was identified in report HF that is a driver or is correlated with mortality is the use of guideline-directed medical treatment. And here there were big differences again between the different regions of the world, with Eastern Europe actually having quite a high use of guideline-directed medical treatment, so ACE, ARB, beta blockers, MRA, both at discharge as well as at 6 months follow-up. So this is one thing that is, we know that there is a correlation with mortality. But there were also other aspects that were identified, like time to first treatment for heart failure, both intravenous or any treatment for heart failure was quite different, with the US actually taking the longest time. Eastern Europe again was relatively fast. And there are different aspects that influence this. I mean, the severity of disease and how the patient presents to the emergency room or to the hospital, and what level of congestion they have. But of course, then there's also aspects of the system that might influence that, such as how crowded emergency rooms are and what the waiting times could be.
Mm-hmm. Thank you so much, Rachel. Alicia, my next question is for you, because you also co-authored a study, but that looked at data from a particular country in a particular registry, which was the Swedish heart failure registry, known as SWEDE-HF. Can you tell us a little bit about the results and what prompted your interest in studying this particular topic?
Yes, of course. Thank you, Gergana. And I'm happy to be here and talk to you all during this webinar. I will start with the last question because I think it's a very good introduction to the study that I did. And that's because during the beginning of my PhD, I used to work in the UK, where I worked with a general practice data set with over 5 million people included. And I was studying heart failure in that data set. But every time I wanted to propose new research questions, we kind of ran into a problem, and that is that we didn't know the subphenotypes of heart failure. So heart failure as a clinical syndrome has 3 different subphenotypes, which is heart failure with reduced ejection fraction, mid-range ejection fraction, and preserved ejection fraction. And these different subphenotypes, they have differences in treatments, there's differences in diagnosis and differences in survival. So I wanted to study these characteristics, but I wasn't able to because this ejection fraction is not standardly collected in the data that we were using. So my idea is that I would create a prediction model for ejection fraction in the Swedish Heart Failure Registry, which is a very, very nice registry in Sweden, where they collected clinician-judged heart failure patients, and they have a lot of information on these patients. The registry started in 2000, and throughout 2003, it was widely implemented in Sweden. And the study that I did was in 40,000 heart failure patients, and we knew what their ejection fraction was. So therefore, we could create a model with clinical characteristics, age, sex, medication use, but also if patients had diabetes or hypertension. And we could create a model with which we could predict ejection fraction. And the model that we created, we could predict 70% correct the ejection fraction status of patients. So with this information, now we can use this model that I created in different data sets that we do not know the ejection fraction for. So for example, the study in the UK with 5 million people, we can now figure out of the heart failure patients that are in there, what their ejection fraction status is. And that means that we can use this data more effectively to study heart failure in the general population.
Thank you so much. Very interesting. And to follow up on that, Stefan, you were a co-author on that study with Alicia. Can you tell us what do these findings mean specifically for healthcare practitioners as well as patients in the European region? And maybe if you can give us some examples.
Yeah, absolutely. Yeah. So these studies, I think, are important because, as I said in the introduction, heart failure is seen by a lot of physicians, not just cardiologists. And these registries show a less restricted patient population. So more patients are captured and we learn about more how we can better treat those patients. And that's, I think, the thing about these registries is that they serve two purposes. So obviously, we're interested in studying heart failure and how heart failure works and interaction between drugs, as a recent example by the group from Adriaan Voors, a professor in cardiology in Groningen, showed together with Carolyn Lam with the Asian HF registry that women tend to benefit from in these data with lower dosages than we previously anticipated. So those insights, I think, can really improve how we manage these patients. And the other purpose is that in and of itself, a registry improves care. And I think Professor Lund from the Swedish HF registry showed that time and time again on conferences, and as well he should, that the moment patients are being included in the Swedish HF registry, already treatment increased. So patients enrolled in the registry, if a physician has to, mark a dosage for an ACE inhibitor, he tends, I think, to, that there's an incentive to increase treatment, and that's actually the case. So patients, once enrolled in a registry, also tend to be better treated, and that actually led to a difference in mortality and also in heart failure hospitalization in patients seen within a heart failure registry compared to patients who are not enrolled in a registry. So there's a sort of again, as I said, it's two purposes. So we can study heart failure in a less restricted way than we previously did, but also we actually can improve heart failure care by enrolling and measuring. As Rachel pointed out, so Eastern Europe, I think we can learn, from their experiences, and also I think it could drive in a positive way as sort of a reference, a benchmark, how well do we treat these patients? Because particularly for heart failure with reduced ejection fraction, we have so many options in the armamentarium, drugs, devices, and we can go on, the list goes on and on. So a lot of actually, room for improvement in patients with heart failure and reduced ejection fraction is actually implementation rather than innovation.
So since you mentioned implementation, if researchers are interested in using this model with their own data, can they do that? How can they do that? Do they need to be a part of a network, or can they do it on their own? What's the approach?
Yeah, that's a good question. So ultimately, we hope to do research which can be used by other groups as well. So one of the things we've been doing is developing a model to predict ejection fraction in the Swedish Heart Failure Registry. So when predicting ejection fraction, we can make better use of data in which that hasn't been captured. We've published that, so that's the beta coefficients to regression formula is open, but again, research is collaboration, so it's a very little effort, I say, to just send an email to the corresponding author. I think Alicia is corresponding author, and you know, I think we are, but I think other groups obviously are more than welcoming new collaboration, or at least helping each other out. So this can be used already by anybody who likes to better phenotype heart failure in their own data sets.
Great. To switch a little bit from discussing the clinical implications and the research implications to a policy level, Rachel, I'd like to get back to your research to ask you what makes your study relevant to the European healthcare ecosystem as a whole, including policymakers, health services organizations, managers, leaders. Are there any takeaways that they should pay attention to in particular? Any actions they can take to address disparities in their respective workplace or system? Or what levers should be pulled at a system or policy level to reduce unfavorable heart failure outcomes? So the broader implications of your research.
No, thanks very, very much for the question, Gergana. And I think Report HF has multiple messages that are relevant to the healthcare ecosystem in Europe as a whole, together with findings from many of the other registries as well. But the first one maybe, and Stefan had it in his introduction, but I think it's important to reflect again on the burden of heart failure and take this broader perspective. I mean, it's estimated that it's over 15 million people in Europe alone living with heart failure. And then if we look at the results of a 20% 1-year mortality for patients that survived hospitalization, I think that that's something to take the time to reflect on and ensure that there is significant or sufficient awareness among the public professionals and also policy decision makers. Then the second point I would like to flag is coming back to what I referred to in terms of the outcomes. So there were really large regional differences in the proportion of eligible patients that received the guideline-directed medical treatment, and also were following up on this. And given that's correlated with mortality, that seems a place to address and ensure that there are heart failure strategies with goals to ensure that the patients are on the right medications and can also have access to post-discharge care to ensure that the heart failure management over the long term is being continued. And one of the findings here that we had in Report HF that was also published is that there was also big differences in the management of the patients and the outcomes in countries with high versus low income, as well as in countries with higher or greater income differences and inequality. And for me, that's also something that is worth further investigating and assessing on a systems level for areas with higher inequality. How can we ensure that the patients there are not disadvantaged from receiving care and have to suffer from worse outcomes compared to other regions, whether it's country by country or within country as well. Mm-hmm. And then I think the post-discharge care, and Stefan has also alluded that heart failure patients are seen by specialists, many different parts of the health system. So integration of this care is something that seems to be very important to ensure post-discharge follow-up of the patients. And then that's even just looking at the last part of the journey of the patient, as we saw in the introduction, but bringing awareness and care to the earlier stages and try to prevent hospitalizations altogether would be worth focusing on. So these are some of the aspects I think we could consider and ensure are included in heart failure strategies, having the dedicated strategies, having protocols in place that also include interdisciplinary care where possible.
Mm-hmm. Thank you so much. So that's a very nice beginning to end kind of overview of actions that managers and planners can take. And to take it back to Alicia, what practical actions or tools do you think researchers, policymakers, and governments can take to actually generate these modern databases and data systems that would enable this research to continue, this heart failure research? We can mention the verification of data. There are particular considerations there. And then broadly, how can we tackle this problem in the short, medium, and long term? Can you give some pointers, perhaps?
Yes, of course, I would like to give a try. Of course, the verification of data is really important, especially in the research climate that we're currently working in. So we all want our data to be fair, findable, accessible, interoperable, and reusable. And I think a lot of efforts already being made towards data being more findable and accessible. For example, the Swedish heart failure already has a metadata platform on GitHub, so open access. Anyone can see that this data is there and that people can use this data, or how to use this data, or how to write a research proposal to get access to this data. So I think we're already making a lot of effort into this, but more going towards the end of the fair, looking at interoperable and reusable. So short-term things are like the study that I did, creating an algorithm to see if we can predict ejection fraction, so we can make better use of data sets that are already out there. Electronic health record data sets are used for administrative and clinical purposes, but it would be so nice to reuse this data as well for research purposes. And currently that's lacking. So I think there could be a lot of more things going on in the future for long-term plans, and not only from the scientists or from the researchers, so going bottom up, but also going from policymakers, from top down. I think we need to talk to each other and see if we can improve technologies, infrastructures, and frameworks to make data more reusable and interoperable with each other. And there's already things going on right now with common data models, so making data more harmonizable and standardized between different data sets, so that different researchers from different countries, or actually researchers from 2 different hospitals, can compare their data in a standardized format. I think this is very important, and I think there should be funds made available to stimulate this further for the long-term implementation.
Mm-hmm. Thank you, Alicia. So this webinar is a Big Data at Heart webinar, so I can't not ask Stefan, how does this type of research fit into the body of knowledge that's being generated by Big Data at Heart and advancing best practices? How do you see all of these pieces fitting in together?
Yeah, so I think it's really sort of a showcase what you can achieve with these newer forms of data over conventional small data sets. So again, previous data sets were small, sequestered. So in other words, they were just capturing one bit of information. And with the advent of these new registries, but also with the advent of making use of electronic medical records, I think we can really advance heart failure. So, the example I like to make to students when I teach classes about this is that in the 17th century, you had causes of death which were descriptive, like fainting in bath and inscrutable pain in the stomach. That's being a label cause of death in the 17th century. And, we can make fun of that. But if you think of it, the first trial with an ACE inhibitor, the consensus trial in heart failure, actually one of the enrollment criteria was an enlarged cardiac silhouette on a chest x-ray, which, I still use in clinical practice, but it's, you know, it's been taken over by echocardiography, by magnetic resonance imaging, CMR. So in other words, you know, we tend to use what we have. So heart failure, but also other diseases, you know, disease phenotype follow knowledge and available tools, and vice versa. So what I hope to achieve with big data at heart is that, you know, we can go beyond the boundaries of previous data sets, and you know, we do that by looking at the disease trajectories. So as I said, you know, heart failure is being diagnosed with a certain set of clinical investigations, but if you look about the electronic medical records of these patients, maybe we can detect signals which, you know, sort of hints towards heart failure, you know, years before they often become symptomatic. So studying disease trajectories is, I think, very important, and that's a focus of the research from big data at heart. Mm-hmm. And other projects, which I hope you don't going to press me with difficult questions, because by no means an expert, but, you know, genomics, proteomics, you know, we've been enriching data, different data sets in the Big Data at Heart Consortium, really to go, you know, the next level, and to answer, you know, in heart failure, the why question, you know, why does a patient have heart failure? And many more genes become apparent, and some even, you know, in preclinical phases have become treatable. So actually it is, you know, these are very exciting times, and I think Big Data at Heart tries to make most use of newer forms of data.
Very interesting. Thank you, Stefan. We are coming towards the end of the questions for our participants, and we would like to open the floor if there are any from you who are listening and watching us. But before that, I'd like to ask one final question to all three of you. So far, we have been talking, you have been talking and discussing, explaining research, how it relates to clinical management, what other researchers can take from it and apply. But if we want to expand this whole work and the contributions beyond researchers and policymakers, can we involve patients as well? Is there a role for patients? How can they contribute and participate? And also, if you are involving patients in your own research or practice, in what way are you doing that? What does it look like? So it's an open question for all of you, and whoever wants to start, please feel free.
I think the role of patients in research is extremely important. And I think that patient participation is currently not being used enough. I think we all agree that more can be done. Within the Big Data at Heart Consortium, there's also studies for wearables. So this is really, really interesting research that's being done using it from your smartphone or your smartwatch, and looking at this data that's being generated by the patients and investigating this. But there's also patient questionnaires, and I think Rachel can tell more about that with Report HF.
Thank you, Alicia. And I fully agree with what you just said about needing to involve patients and the patient's perspective more. So of course there are outcomes that are being reported by the patients, and to come back to Report HF, we did include patient-reported outcomes in terms of quality of life, both for the disease specifically as well as in general in Report HF. We actually also, to bring an additional perspective in as well, we did include also outcomes on the caregiver burden, so to understand not just the patient perspective but also their loved ones, and how the disease affects the wider the wider environment and the family, and in some cases friends of the patient as well. So I think understanding from the patient perspective the outcomes, what's relevant to you. Collect data directly from the patients is essential, but actually beyond that, I think involving the patients or patient representatives in the design of studies and future registries would also be essential, to not only to listen what they have to say once we decided what we collect, but actually decide together what should be collected as well, so to make it as meaningful as possible to the patients too.
Mm-hmm.
Yeah, I agree. I think the patient engagement, you know, the fair answer is no, not enough already. I think a lot of projects we currently do, I think patient engagement can definitely be improved. I think the awareness, not only from researchers, but also policymakers and funders, you know, it's on the agenda in, you know, preparation for a recent grant about a registry-based trial in the Netherlands. Patient involvement is one of the prerequisites. As well, it should be, but so policymakers, you know, and funders can really make a difference. So that the Dutch, and I think other societies as well, but the Dutch Heart Foundation, you know, makes it a premise for work. I think just like open access, you know, it's something which I think the field should evolve. So we should take steps, but I think it's at a lower pace than we, and definitely I think patients wanted it to go. Yeah.
Mm. Well, on that note, I'd like to invite questions from our audience. If anyone would like to ask us, let me remind you that you can type your question in the Q&A box, and all of our panelists can see them. So please be bold, ask us questions. While we wait, I'll take the opportunity to, oh, here we have one. So a question from Caius Ovidiu Mersa, I hope I'm not butchering the name, is asking, are these, will these databases be public, or will they be accessible from third-party health apps? I suppose it's referring to the registries that you have worked with, or the databases built based on your research.
I can answer this question for SwedenChat, for example. Data set's not public. Metadata is available, so people can see what type of patients are in there, what the characteristics are. But in order to get access to the data, one needs to submit a research proposal and a research question to the board to get access to the data, and then to do research with that. I think that's the answer to the question.
Okay, thank you, Alicia. I don't know.
And to add to that, so very similarly, I mean, report HF is not publicly available, but if anyone is interested to work with the data, of course, you can reach out either to Novartis or to the members of the steering committee, which you will find on the publications, including the contact details of corresponding authors there.
Mm-hmm. Okay. Well, while we wait maybe for some other question, I have another question which I think you may find interesting, relevant. What do you see as the most important upcoming initiatives in relation to data generation for heart failure? Is there anything that's lined up next that's coming? Or what are the biggest gaps, if there are any? And what would you expect the impact of filling these gaps to be?
Well, I think I think the Swedish are ahead by a landslide. So in the Netherlands, we're taking initiatives right now to have a Dutch heart registration. We use that already for procedures like pacemakers, ICDs, as a prerequisite. So we have to, provide data about complications, etc. But we also want to use that platform to have a heart failure registry in the Netherlands. But apart from national initiatives, I think, in Europe, the ESC has it high on the agenda. So we have the Atlas, which hopefully can mirror the American report, the heart statistics, which come out every now and so often. So I think that's a not only well cited in terms of research, but also a much used document which provides insight about heart disease. So I think in Europe, I really welcome the endeavor of the Atlas. So that's from the European Society of Cardiology, and Panas Vardos is taking a lot of work to really make sure that we can generate these numbers, and as I previously said, to learn from each other how we can improve clinical practice.
Mm-hmm. Okay.
Yeah, maybe to.
Sure, go ahead, Rachel.
No, maybe to build a bit on that, I think another initiative focusing on Europe to look at is the EuroHeart initiative as well, which looks at data infrastructure as well as kind of common data sets in terms of variables to be collected that looks across multiple European countries and taking a lot of learnings from SpeedHF and bringing that to other countries. And I think that it will be a great initiative in terms of data availability.
Mm-hmm.
But then also new things in addition to what we discussed today, learnings that might also be a platform that allows for more registry-based randomized trial, which could benefit or make the development of new products or use of products in other indications a lot more efficient, which I think would in the end benefit patients as well. And what I also like about this initiative is that it looks at the broader data infrastructure perspective as well, because we've discussed a bit today on absence of some of the information that is needed. I mean, Alicia was alluding about the ejection fraction, actually found with her model a way around that. But then in addition to ensuring we collect the right things, can we collect them in a way that they might become more transferable as well? So that's an initiative I would highlight.
Mm-hmm. Thank you, everyone. We have a question asking whether any of these registries are collecting omics data. So somebody's interested in that.
I think as maybe a nested cohort. So I think maybe part of that population can be enriched with omics, but it is, well, at least in the Netherlands, it's not part of the first rollout. So I don't think it's collected on a standard basis. I think it's collected in smaller subsets of patients. Yeah.
Mm-hmm. Okay. And we have another question from Marilena Vrana. She's asking, can a patient have access to and withdraw their data from a database, whether it's a registry or a database from a medical device, if they wish to?
Yeah, that's, I think, a very, very relevant question. And it comes to, faith from a patient, that his or her data is used in a sensible way and it's anonymized appropriately. So in the Netherlands, again, for the heart failure registry, there's what we call the opt-out. So we have permission to collect these data. Patients are being informed that these data are used in an anonymized fashion. So in a trusted third-party setting, the data is de-identified and then used for these purposes. So patients can opt out, but it's different than a trial where you have to opt in and give informed consent. So collecting that data is done obviously with ethical approval, but it's done on an opt-out basis.
Mm-hmm. Rachel, do you want to say something, or?
Yeah, I mean, I think this varies greatly depending on which registry or which system, which country we're looking at, whether patients actively opt in or just opt out, as Stefan just alluded. And this, for example, the UK system also works like that. I mean, their primary care databases. And then also there is variance on how easy it is for patients to access their own data or parts of their own data, depending on the country and the specific study in question. But I mean, the points around anonymization and keeping, you know, privacy and security of the data is of course essential. And
yeah, as we can see, there are many questions about data standardization, access, privacy, and so forth. So I think in the background of all of these questions, there's one big question related to sharing of data, as many institutions are not always very willing to give access to their data for various reasons. For example, in Germany, there could be the case that two hospitals in the same city are using different platforms, different EHR perhaps, and they're not willing to exchange the data, even in the case where it's the same patient, for example, needs to go from one hospital to the other for some reason. So what can be done, do you think, to address these barriers? Some of them are cultural, others more political. Is there a way to start addressing them? What do you think?
Well, I think it's, first of all, for the patient, very important that if they go to one hospital and then to another, that their data can be transferred securely between these two different hospitals. But for research purposes, more my field, having a standardized way of collecting data and harmonizing data between different hospitals or different countries is so important. We get more information and we can compare differences on a population level between European countries, for example. And these things can be done completely separately, so there will never have to be an exchange of data. With common data models, we can standardize data in two different hospitals to the same platform, but there will never be an exchange of data. But we can still compare them in a standardized way. And I think that's something very important that we can learn from that.
Yeah, and sometimes, Gergana, to expedite, you know, collection of a minimal data set, unfortunately, you have to impose some sort of financial incentive. So, in other words, if you implant a pacemaker or ICD in the Netherlands and you don't give your data about complication rates to the central cardiology society, you know, you can actually have your license or reimbursement, you know, become yeah. So in other words, sometimes if we agree this is the minimum you have to apply, you know, to have up to standards in quality, also in data collection, as you can say, sometimes reimbursement can be an effective way to achieve that.
Mm-hmm. I guess those answers actually preemptively answer another question that has just come in from Marilena Vrana again. She's asking about data standardization. Do you think that a minimum standards framework can be imposed from regulators for electronic health records, registries, and medical device databases? I guess some of your previous answers, you know, got to that in a way, but to answer Marilena's question, what is your take?
Yeah, I think it's really interesting to investigate this. However, there are instances where the definition of diseases might vary per study question. So then if we would impose a minimal standardized set, we would lose that extra information that we have if we collected more. But with common data models for each different research question, we can set up a new standard, a new definition of data that's sometimes wanted because we want either a broader definition or we want a smaller definition for a disease. So I think with platforms such as common data models, we can take those things into account.
Mm-hmm. Anyone have a different take? If not, I have one more question for you. Also, it's all related. We are now talking a lot about data standardization and access. So, Stefan, you already mentioned that one way to incentivize institutions and practitioners to share data may be through financial incentives. Is there, question for everyone, what do you think is the internal or inherent conflict for not wanting to share data? Could there be another way to encourage researchers and institutions to share data that beyond financial incentives? Is there any other altruistic means of encouraging them?
Well, I think researchers are always enthusiastic about having data to work with. I think the real problem is the administrative burden really from physicians. So I think we increasingly have to collect a lot of data, not only for research purposes, primarily for healthcare, just to care for our patients. Mm-hmm. So I think time restraints are really something in place, and so we are trying to enroll this heart failure registration. Hopefully, as you said, people will be altruistic and will be involved and start collecting these data, but it will still involve a lot of time, which I think, as in many other businesses, I think time is our most constraint there. Mm-hmm.
Just to introduce one more element, in addition to data, there's a lot of talk about AI and automating various aspects of the clinical research process. So to maybe to help alleviate some of that administrative burden, do you see a role for automation and AI, or is that still more at the level of wishful thinking, but not so much practical?
Well, clinical practice can be helped, absolutely, I think, with AI. So for example, radiology, it's not going to replace a radiologist, but it does help facilitate a radiologist to do his or her job. So I think there's definitely there. Maybe Alicia or Rachel have some ideas about from a research perspective. I think there are many elements to AI that is appealing.
Yeah, indeed. So, for example, there's something called a computerized decision support system that can be implemented in electronic health records, and that kind of can have different meanings, but it can automate something. So, if a physician fills in certain risk factors for a certain disease, then behind the scenes, a model can run and calculate the risk for that patient for 10-year risk of cardiovascular disease or heart failure. And it can also look into the medication use and look at whether this is up to standard for the guidelines and if there are any contraindications. So a lot of things can run in the background of electronic health record systems to help inform the physician for decisions that they can make.
Yeah, and I think in addition to that, with larger data set, there's also a role for AI in helping to understand the disease itself. different populations within a broader disease population. I mean, with heart failure, because it's such a diverse range of signs and symptoms as well, to get a better understanding of differences within the population. I think there was a question on omics before, right? Also going to a deeper understanding of the disease from a molecular genetic perspective as well. So I think there's definitely some important insights that AI can support. But I also want to comment on one of Stefan's point about administrative burden. And I think this is not necessarily AI, but maybe more automation, so that we can avoid double data entry into different systems, but somehow try to use data entry that already happens and enhance this, rather than having separate systems where people have to spend time entering similar data into different systems, in terms, to give the data to registries, but also have it in the right claims systems, so the billing goes through. So to avoid duplication there, I think in many systems that might be also quite beneficial, and free up time potentially, in my personal opinion.
Mm-hmm.
I absolutely agree, and I think the CPRD, so the primary care data set from the UK, is, I think, one of the finest examples to that, so that a primary care general practitioner actually works inside a electronic health record which is compatible with that data set. So he fills in, medical records, but that's automatically used and structured into the CPRD data set. So that's without going through the extra hassle of manually entry of data. Absolutely.
Thank you so much. I suppose this is a good way to end our discussion today, and maybe that calls for a whole new webinar on AI in clinical research and practice. So we can definitely think about that. I'd like to thank our panelists for your generous contributions, your time, and your insight, and also to all of our viewers and listeners, everyone who's on the other side of the screen. Thank you very much. It was a pleasure having you, and thank you for being with us, and I hope you enjoyed it. With that, we'll close the webinar today.